Lung cancer is the leading cause of cancer death worldwide. In the US, estimated for this year, 2025, over 226,000 people will be diagnosed of lung cancer, more in women than men, and about over 124,000 people will die of lung cancer this year. Most of the lung cancer that we found currently, when they're diagnosed, they're at late stage, when treatment options are limited, and if we can find them earlier, early detection and through screening can dramatically improve their survival. And low-dose CT screening is the tool to help us to find them earlier. So let me talk about low-dose CT a little bit, but I'm just going to quickly go through it. Why we use low-dose CT? Because it's very quick. The scanning portion of it takes only 10 seconds once you get onto the table. The picture here on the lower corner is the CT scanner. So you just lie on this table in a donut-shaped machine and just go in and out to have the scan. It's painless, it's non-invasive, and it has much less radiation than the CT scans. So to give you a sense of the radiation, it's less than, currently with the advancement in low-dose CT, the scanner is less than 1 millisievert, and living in Denver or Colorado, you're already exposing as high as 11.8 millisievert per year of radiation. So low-dose CT can detect smaller nodules before symptoms of lung cancer appear. So this is a picture that shows you when a nodule here is 2 millimeter, we can already see them in CT. But using chest X-ray, you will have to wait till the nodule gets us 1 centimeter, then you can start seeing them in chest X-ray. So CT is more sensitive, and you can find nodules when they're much smaller. So our group, the Early Lung Cancer Action Project, Dr. Henschke and Dr. Yankelowitz started in 1992 and enrolled their first patient. This is our first publications, and it was also, the publication was also published in New York Times. It shows that our study shows that routine chest X-ray is not as good as CT in detecting early stage lung cancer. In our study of 1,000 participants, for those who underwent chest X-ray, 57% of them were stage 1, which means stage 1 is an early stage lung cancer. They're more curable and smaller. And when people who were diagnosed with CT, 85% were early stage lung cancer. And after our 1999 findings, there are up to at least 2 large randomized controlled trials, large study that also looked at the use of low-dose CT in diagnosing lung cancer. And they have also shown that using CT, it can reduce lung cancer mortality. And in 2015, because of all these evidence, US government, the Center of Medicare and Medicaid, issue a national coverage to all the Medicare. So people who are at high risk of lung cancer, they can get Medicare coverage to get low-dose CT. So all these studies have shown that low-dose CT screening is proven to save life, and annual low-dose CT screening is now an accepted tool for early detection of lung cancer. So who should be screened? Currently, starting from 2013, in the US, they already started to recommend low-dose CT screening for high-risk population, and they have modify who's eligible recently, a few years ago. And so right now, for Medicare and Medicaid coverage, people who are age 50 to 77 with 20 years of smoking history or more, and those who are currently smoking or quit within the past 15 years, they are eligible for low-dose CT screening annually. These are some of the risk factors for lung cancer. The key risk factors is smoking, as we all know, but even though you're not smoking, exposure to radon, occupational exposure, such as asbestos and some other hazardous agents, air pollution, or secondhand tobacco smoke exposure, you work in a workplace that your coworkers smoke, or you live in a household that your partners or family members smoke, you are exposing to secondhand tobacco smoke exposure, and also family history of lung cancer. So screening is a process. It's not a one-time test. In order to benefit from screening, you're supposed to go get annual low-dose CT, and instead of just showing up and get one scan and not coming back. So this shows that from our ILCAP, 1999 studies in ILCAP, we started with only 2 institutions in New York City. We have now grown to over 80 institutions worldwide, over 100,000 participants, and some of them we've been following up long-term up to 25 years. So we have a lot of data when patients return and all the follow-up and whether they diagnosed of lung cancer and all the intervention. So with that information, we recently published the lung cancer survival rate. It has shown that we first published our 10-year survival rate a few years ago. It shows that 80% of those who diagnosed of lung cancer under screening, they have a long-term 10-year lung cancer survival rate of 80%. And now that we use our longer follow-up data, we consistently show that the survival rate is about 80%, which means that 4 out of 5 people diagnosed of lung cancer under screening will be cured. And they are really cured, and as we follow up them longer, the survival rate remains the same. So low-dose CTE not only can visualize lung, and on the low-dose CT, we can also see different other organs. So we can see that we can see this as an annual health check of all these different organs. And this is our recent long-term follow-up paper looking at coronary artery calcification. So these calcification and detect on the low-dose CT is the most reliable determinant of cardiovascular disease. So we have a way of quantifying how much calcium, coronary artery calcium, is in your arteries from the low-dose CT. So we have a score from 0, meaning no calcium, to 12, meaning the maximum amount of calcium for each patient based on their low-dose CT. And we have shown that just from one baseline CT, we can predict long-term, 25 years down the road, your likelihood of developing cardiovascular related disease, cardiovascular related death, and all-cause mortality. So here is our result. We show that those with higher score, our coronary artery calcium score, has a higher likelihood of developing cardiovascular death and also all-cause mortality. And those who has the highest calcium score in that group, the severe group, they are almost 4 times more likely than those who have no calcium to die of cardiovascular death, and 3 times more likely to die of any causes. So we show that with one CT scan, when you can actually predict survival many years later. Here is also showing the overlap because both cardiovascular disease and lung cancer, they are smoking related diseases. So the smaller circle here shows that in the US, how many people are eligible for a CT scan of the lung. And then you can see in the bigger orange circle how many of them are eligible for coronary artery calcium scanning. So you can see that majority of those who are eligible for lung scan, they are eligible for calcium scan. So it makes sense that when we look at the lung, we should also look at the heart. Besides the cardiovascular diseases, emphysema can also be visualized on CT, and it's a very good predictor for COPD and lung cancer death. And also on CT, we can quantify the amount of emphysema in your chest. We can grade them in none, mild, moderate, and severe. And we have also shown in our recent publications that with your baseline scan, we can predict 25 years follow-up of whether you will die of COPD death. And we have shown that if you have emphysema, you are 3 times more likely to die of COPD death, and also how cardiovascular death is a little more than, is 14% higher. So when we talk about trying to encourage people for undergoing low-dose CT, a lot of patients or participants have questions about radiation, false positive, and the cost of low-dose CT. So I just want to briefly talk about this. And radiation, as we mentioned, that low-dose CT has very low radiation. So the benefits of being early detecting all these different diseases outweigh the risk. And false positive, because CT is very sensitive, you can see many different findings, and a lot of people worry that it will trigger invasive procedures and unnecessary workup. So as more advanced technology, AI, and better management protocol, as we would learn more about these diseases, we know how to manage these diseases. So we know which features and what things to look for and what not to act on it immediately. And the cost, as I mentioned earlier, Medicare currently and some insurance plans currently cover low-dose CT, so that is not as much of an issue. And if you think about all the diseases you can detect with a low-dose CT, it's a really cost-saving exam. So currently, there are a lot of exciting research around this field. We are trying to find ways to better predict lung cancer. With the AI tools, we can do image analysis better and improve accuracy of these different findings. We can personalize management of your CT findings, and then we will try to reduce unnecessary invasive procedures. And we also have a study identifying optimal treatment for early stage lung cancer, as more and more early stage lung cancer are being detected. And at the end, we also want to develop an integrated screening pathway for this comprehensive health track. So in conclusion, lung cancer screening enable long-term survival for sustained benefits over 20 years, we've shown, and a single CT can predict long-term risk. And it really empowers people to take early action. If you know that from your CT scans, you're at high risk, and perhaps you want to modify your lifestyle, quit smoking, exercise, or more adhere to the medications that doctors prescribe you. And at the end, long-term follow-up data highlight the value of low-dose CT. We're able to detect multiple diseases such as lung cancer, cardiovascular, and COPD within a single CT scans. That's all.